Okay? Again, we look at a case study. A 65-year-old man presents with the complaints of difficulties with his vision, particularly at night. Okay? Blurred vision is primarily in the right and left peripheral fields, so he cannot see very clear on the sides, but in the middle he can see okay. All right? He has myopia and he wears the corrective glasses like many of us here. Okay? When you examine the patient, you find out that the visual acuity is reduced. It is 20/100 on both sides. And on the examination of visual field, you see that there is visual field defects on both sides. Okay? Now we will review the physiology of the eye, the mechanism of detection of light and interpretation of visual images in the brain, and then we will come back to this case and we will try to understand each one of these and what could be the possible cause. Okay? Alright, now the eye is a structure which has multiple layers. The outermost layer is called sclera, okay? And the front part of sclera is called cornea, which is transparent, allows the light to enter, okay? After this, the second layer is called choroid. This is a layer which is containing all the blood vessels. It also contains a lot of melanin, so it absorbs extra light that enters the eye. Okay? The front part of choroid is known as the iris. Okay? And in the middle of the iris there is an opening, there is a gap which is called pupil. And you can increase or decrease the size of pupil to allow the amount of light to enter the eye. You want more light, the pupil dilates. You want less light, the pupil constricts. Okay. And behind that, you have a transparent lens which is suspended from all its sides from the periphery. This lens can change its thickness. So it can change its refractive power. Although the refraction is most at the cornea because of the curve, but important refraction occurs at the lens because this is something that you can change. The lens can become more globular, can become more thinner. Okay? Behind the lens, the innermost layer is the retina, which is the sensory part of the eye. You have rods and cones there and other cells, as we will see. Okay? And the light will pass through all these different layers, will reach the retina, and then it will be detected by the photoreceptors. Okay? Everybody clear about this? Now, there could be certain errors of refraction. Refraction means the light, when the light rays bend, they do not focus at the place where they should, which is on the retina. Okay? So if there is some problem with refraction, we call them errors of refraction. There are mainly 4 common errors: myopia, astigmatism, hyperopia, and presbyopia. This is the most commonest one. Okay, and many examples are present here, right? Myopia, okay? So what happens in myopia? Either the eyeball is too big, okay? Either the eyeball is too big, or the lens or the cornea are too strong. The light rays are bent before the retina. So the focal point actually is before the retina. Okay? In case of hyperopia, the other one, either the eyeball is too short or the lens is weak and it is unable to bend the light rays at the retina, and the focal point actually is behind the retina. Okay? Now, myopia occurs when you are looking at distant objects, because light rays coming from distant objects are parallel. When you're looking at things which are near to you, the light rays from this source are actually diverging. Okay? So if you see here the difference, here the light rays are parallel, here the light rays are diverging. So in this case, the lens has to do extra effort to bend the light rays at the retina because the light rays are diverging. So lens needs to be more stronger, more globular, increase the refractive power in order to focus the light on the retina. Okay, so that's why myopia is where you can't see the distant objects clearly, which most of us are suffering from. Well, no, most of us, few of us. Okay. And hyperopia is where you can't see the near objects very clearly. Okay. Now, how do you correct myopia and hyperopia? You can help the refractive power of the eye. In this case, you want to reduce the refractive power of the eye. In this case, you want to increase the refractive power of the eye, right? So what do? In case of myopia, you add a, what type of lens? Biconcave lens, because this will oppose, this is a biconvex lens, right? The one which is naturally found in the eye is a biconvex lens. This is a biconcave lens. So you are nullifying the refractive power of the lens, reducing it, so the light will focus on the retina. In case of hyperopia, you want to help this lens, so you add another biconvex lens in front of the eye, right? So the light rays will focus now on the retina. Okay? Astigmatism is another error of refraction. Okay, it is also for when you're looking at distant objects, light rays which are coming parallel. In this case, the problem is that the cornea, the curve of the cornea is not smooth across different planes. Okay? So in one plane, the cornea is properly curved, but in another plane, the cornea, say, is slightly flat. So certain light rays will focus on the retina, but certain light rays which are in that particular plane where the cornea is more curved or flat, whatever it is, will not focus on the retina. So in this case, you have to add a lens which only corrects the light rays in that particular plane. Okay? So as you could imagine now, for the correction of myopia in the previous slide, you can wear contact lenses, right? They move around any plane, doesn't matter. But for astigmatism, can you wear contact lenses? It's difficult because the contact lens will, your glasses, they're fixed. If you have, say, in this plane, you have a power, it will stay in this plane. But contact lens can move in any direction. So it's difficult to wear contact lenses if you're suffering from astigmatism. Okay? Presbyopia. Now you must have seen your grandparents looking at the newspaper far away, right? Okay? This is called presbyopia. It is similar to hyperopia, so unable to focus the light rays which are coming from a near object. In order to understand presbyopia, you need to understand accommodation reflex. Okay? What is accommodation reflex? It is part of what is known as the near response. Okay? Now, I want you to do a simple exercise. Okay? Just hold your finger in front of you. Look at me, not my finger. Look at me, and now look at your finger. Okay? When you do this, you're looking at far object, and suddenly you look at near object, three things happen. Number one, your eyes, both your eyes, should move medially, right? To focus, to look at that near object which is near to you, which is called convergence of the eyeballs. Second thing, the pupil should constrict. You don't want too much light to enter the eye because you're looking at the near object. The third thing is accommodation. Accommodation means, you see the light rays coming from the far objects were parallel. Your lens was able to focus them on the retina. Okay. Now do the same exercise again that I asked you to do just now with the finger. For the first fraction of a second, your finger was not focused, right? And then it came into focus. When you look far away, suddenly look at the finger. For the first fraction of a second, your finger was not clearly focused, and then suddenly it came into focus. What happened now? Suddenly, when the light rays which were coming parallel, now light rays are coming from near object, they are diverging. If the lens remains of the same refractive power, the focus goes behind the retina, right? In order to bring the focus back onto the retina, the lens should become more globular. It should increase its refractive power. Okay? So this happens by the accommodation reflex, lens becomes more globular, and this happens by the ciliary muscle which is around the lens. Okay? The ciliary muscle contracts, so the ring which is around the lens becomes smaller. When the ring becomes smaller, the lens becomes more globular. Okay? And this muscle, the ciliary muscle, is one of the most highly used muscles in our body. Because all the time the lens is changing shape when you're looking here and there, different areas. Okay? So this is the accommodation reflex. What happens with advancing age? The lens becomes a bit hard and it doesn't accommodate that well. That's why presbyopia sets in. Okay? So presbyopia is basically some problem with the accommodation reflex, and it comes with aging. Okay? This is called near point of vision. Now keep looking at your finger now, okay? And keep bringing the finger near to your eye. After a certain point, you can't focus the finger, right? It becomes blurred. Okay? So the point where you can see clearly is called the near point of vision. With age, because the lens cannot become so globular now, this near point of vision becomes further and further away from your eye. That's why the old people, you see them holding newspaper away from the eyes, because the near point has gone further away from the eye. Okay? So basically, the near point of vision at 10 years of age is at 10 centimeters. So up to 10 centimeters, the child can focus very well. But you see, at the age of 60 years, this is now 80 centimeters. So you have to hold the thing further away. Okay? When reading and close work becomes difficult, then this is called presbyopia. Presbyopia. Alright? And it will be corrected by, similar to hyperopia, wearing convex lens. Wearing convex lenses, right? Okay? Are you clear about this? Now, inside the eye, the retina. Alright? Now, when you're looking at somebody, okay, when you're looking at somebody or any particular place, you can see details of that particular person or place very well. But you also see a lot of area around. Right? Although you can see the area around, but you can't appreciate the details of what you're seeing in the peripheral field of vision. Okay? And the retina is all around, right? Everywhere there will be formation of images. But when you're focusing at somebody, looking at somebody, that image is forming on what is known as the fovea centralis. This is an area which is next to where the optic nerve leaves the eye. This area, the layers of the retina are much thinner, are much fewer, and we will see there are more cones in this area. So the visual acuity, the detail of the vision is very high in this area of the eye. And when you're doing this convergence of the eye, when you look from far object to near object, basically what you want the object to be focused on the fovea centralis. So you can see it very clearly and in much detail. Okay? Alright, now, what happens at the retina? Now the light has reached the retina, how it stimulates the photoreceptors and how the signal is sent to the occipital lobe of the brain. The retina has many cells. If you study the histology of retina, they will tell you 10 layers, right? So there are 10 layers of retina, all right? Functionally important cells I have put there. So basically, there are the photoreceptor cells are known as rods and cones, okay? These rods and cones are here. Then we have the ganglion cells. The axons of the ganglion cells will form the optic nerve, which will leave the eye and go to the brain. Okay. Now between the rods and cones and the ganglion cells, there are some interneurons. Okay, and there are three types: bipolar cells, horizontal cells, and amacrine cells. Okay, the bipolar cells are in same plane as the rods and cones and the ganglion cells, but these two are arranged horizontally: the amacrine cells and the horizontal cells. If you see here, if you look at the retina, the light actually should pass from this side all the way through all these cells and reach the rods and cones which are actually at the back, and then stimulate them to give us the sense of vision. Okay? Okay, now the arrangement of horizontal cells, amacrine cells, bipolar cells is very complicated. Okay? The important point to remember is that the horizontal cells have inhibitory and excitatory type of synapses. For example, a typical arrangement is that the horizontal cells, so if this rod is stimulated, for example, the signal will go to this bipolar cell. Okay? These horizontal cells are communicating with the rod which is next to this rod, and they're also communicating with the bipolar cell of the adjacent rod. Okay? So by this arrangement, having excitatory inhibitory connections, the eyes are able to see objects very clearly. The boundaries are very clear through the process of lateral inhibition. You all know that, right? Lateral inhibition? Okay? To the process of lateral inhibition, so the eyes are able to differentiate between different objects very clearly. You have discrete lines that can separate the two objects. Okay. If you look closely at the rods and cones, you'll find that they have two segments. This is the inner segment, and this is the outer segment. Inner segment has a lot of mitochondria and other vesicles. The outer segment is arranged like shelves of membranes. Shelves of membranes. Okay? In these shelves is the photoreceptor chemical that will be activated by the light. The difference between rods and cones is that they respond to different types of stimuli. Okay? The rods are low threshold receptors, very few photons in the light. So actually for rods, even one photon can stimulate the rod. So they are very sensitive to light, low threshold. Okay? So they are important during the night when the light is very dim. These rods will be stimulated by very dim light. But they cannot see color. They only see light, that's it, light or dark. Okay? The cones, on the other hand, are very high threshold receptors. They need a lot of light to be stimulated, but they are able to see things in much detail and the colors. So for this reason, tell me now, the fovea centralis region of the retina, where the vision is focused when you're looking at somebody, you should have more rods there or more cones there? More cones there, right? So the fovea centralis has a lot of cones, very few rods. But if you look at the total number of rods and cones in the eye, the total rods in the eye are about 100 million, and total cones in the eye are about 5 million. So cones are very fewer as compared to rods. Okay? But the ganglion cells and the axons of ganglion cells, most of the axons are coming from the cones, not the rods. So what I mean to say by this is, for example, 100 rods will converge on one ganglion cell. But in case of rods, one rod, one ganglion cell. Because these cones are able to provide us with very detailed and also color vision. Okay? Now what is happening at those membrane shelves? If we look closer now, there is this pigment known as rhodopsin. Okay. At rest, when there is no light, okay, in these rods and cones, there is some cyclic GMP present, which is the second messenger. Presence of cyclic GMP causes opening of certain sodium channels. So sodium is constantly leaking into the rods and cones. If you think about other receptors, the sodium comes in, there is depolarization and the signal goes, right? But the rods and cones are the opposite. When there is no light, the cells are constantly in a depolarized state because sodium is leaking in. When the light falls, okay, it causes change in this pigment. When the photon strikes there, okay, it causes conformational change. This rhodopsin then goes and interacts with what is known as transducin. Transducin causes conversion of cyclic GMP into 5' GMP. When the cyclic GMP levels drop in the cell, the sodium channels close. Now sodium cannot flow in and the cell membrane hyperpolarizes. So in this case, rods and cones are depolarized at rest when there is no light. When the light strikes, they become hyperpolarized. Sodium can no longer enter the cells. And at dark, in the dark, these cells are depolarized, right? So they are constantly releasing an inhibitory neurotransmitter, mainly glutamate. When the light strikes, the glutamate release stops. Okay, so it is the opposite. You got this point? Okay. Now this retinol, the part of rhodopsin, okay, when the light strikes, it converts from 11-cis-retinol to all-trans-retinol. Now this all-trans-retinol should be converted back to 11-cis-retinol through many chemical reactions for the photoreceptor to respond to light again. Okay, so this part of the rhodopsin, which is called the 11-cis-retinol, is very important for the eyes to see, and this is derived from vitamin A. That's why vitamin A is very important for the ability to see, because vitamin A will provide 11-cis-retinol, which is required for the process of vision. Are you clear about this? Okay. Now, what happens when you are in a very light, very well lit environment and you go into dark? For the first few minutes, you won't be able to see anything, right? But then gradually, you start to see things. This is called dark adaptation. When you are in a brightly lit environment, okay, the rods and cones both were firing, they both were detecting light. When you go into the dark environment, as I told you earlier, rods are much low threshold receptors than cones. Cones will no longer be able to detect. So that's why in dim light environments, you can't see colors very well. The rods will then lower down their threshold even further. It will take some time. So this is called dark adaptation. In order for dark adaptation to occur, you need a lot of this rhodopsin cycle to take place, right? So if somebody is having vitamin A deficiency, the first sign you will see is that this person will complain of poor vision under dim lights. If the deficiency becomes more, then even in well-lit environment, the patient will not be able to see very clearly. Okay, so this is vitamin A deficiency. Okay. It will lead to impaired adaptation to dark, which is called night blindness or nyctalopia. All right. If the vitamin A is not given to these people and the deficiency of vitamin A is chronic, it will lead to permanent damage of the retinal layer of the rods and cones, and there will be permanent blindness. Okay, permanent blindness. So vitamin A deficiency actually is the most common preventable cause of blindness. If somebody comes to you with night blindness and you give that patient a vitamin A IV injection, within minutes the vision will become normal. It is so quickly utilized in the retina, so you can imagine. But if, say in developing countries or malnutrition in those areas, if the children are not given vitamin A properly on time, it could lead to permanent loss of vision. Okay? Any questions about the rods and cones, the differences between them, the process of formation of rhodopsin, vitamin A, anything? Yes? In dark, okay, when you go to dark, the amount of light has reduced now, right? In order to you to see, the rods should respond to dim light, very small amount of light. So their threshold actually should come even lower. As I told you, the rods are even able to respond to one photon. One photon strikes the rhodopsin, the rod will send a signal. But when you are in a well-lit environment, this threshold actually goes up. So when you go to the dark environment, it takes a while for this threshold to drop, and you need a lot of rhodopsin to be generated very quickly. So in the dark, dim light, you will need more rhodopsin to be cycled quickly in order for you to see clearly. Okay, this is what I meant by this. Now color vision, how do our eyes see color? It's by the help of cones. We have three types of cones. Rods respond to all light, as I told you earlier. So all or none principle, light, no light. But cones, there are three types of cones, three populations of cones, each one responding to a different wavelength of light. So based on which wavelength they respond to, they are called as blue cones, green cones, and red cones. Although they are not of that color, right? They are detecting that color. All right? So basically, this is the blue cone which will respond to blue color the max. 100 means that when the color is of this wavelength, the blue cones will be firing maximum. Okay? When the color is of this wavelength, the green cone will be firing maximum or red cone firing maximum. Now, different colors will cause varying stimulation of different cones. So the brain will then interpret the signal coming from different cones and will identify the color. Okay? So for example, if we look at this color, this area here, this one, the green light, it is stimulating the green cones 67%. It is stimulating the blue cone 36% and the red cone 31%. So with this combination, the brain will know which color is it. So with all different types of combinations, our brain is able to see millions of colors based on how much stimulation is coming from each different cone. You got it? Okay? Alright, now color blindness is something which is not very uncommon, especially the blue-green color blindness. This is an X-linked disorder, so affects males mainly. Females are not that affected, they basically are carriers. Okay? Alright? And this is a very serious disorder. Okay? Because these guys, when they got married, when the wife wears a new color, and she asks him, how do I look? And he says, you're wearing the same thing you wore yesterday. What will happen after that? A big war, right? Okay? So this is a dangerous disease. Blue weakness is much less common. Okay? There are certain charts which are shown to the patient. So those who are colorblind, they would read a different number. Alright? So can you all read 74 here? Okay. Can you all read 42 here? Okay, good. Alright. But actually, the blue-green, this blindness, the green-red one, the red-green one, is not that uncommon. Okay? Now, after the retina has done its job, it has detected light, this signal will now be sent to the brain. Okay? So let's look at the optical pathway and perception of vision by the brain. Now, this is a little complicated part, so I need your full attention, please. Okay. If you're looking at the eyes from the top, this is from the top, okay, the right eye and the left eye, okay. The retina is all around, right? Now, if you imagine here, this is the nasal side of the eye, right? This is temporal side of the eye, right? On this side, this is nasal side of the eye, and this is temporal side of the eye. So this half of the retina, I can call it temporal retina, and this one I can call it nasal retina. Okay. When the image is coming from the environment, okay, because eye is like a pinhole camera, image is inverse, okay. The image which is coming from here, for example, will be formed on the nasal retina. And this is, if I talk about the visual field now, the image which is coming from here, is it coming from the temporal field of vision, nasal field of vision? Temporal field of vision. So temporal field of vision, image is formed on nasal retina, okay, and nasal field of vision, image is formed on the temporal retina. Why it is important? Because when you're examining a patient clinically, you're not looking at the retina, you're looking at the field of vision. You're asking the patient whether you can see here, you can see here, you can see here, different areas, right? So you're talking in terms of the field of vision. So when you say temporal field of vision, the problem is with the nasal part of retina. Got this point? So don't confuse this, okay? And what happens here, once the fibers are traveling in the optic nerve, something happens at the optic chiasm. The fibers from the nasal part of both eyes, the retina, decussate. So I could say the nasal retinal fibers or the temporal field of visions of both eyes decussate. Would I be right? Nasal fibers of retina cross over, or the temporal fields of vision cross over. Okay? Because of this arrangement, because they are color coded here now, the red is the nasal retina of the left eye, this red is the temporal retina of the right eye. Okay? These red end up on the right side of the brain. So the right side of the brain, or the right side of the occipital cortex now, is looking at what? The right side is looking at the temporal field of vision of the left eye and nasal field of vision of the right eye. You got it? So we could say the right brain looks left and the left brain looks right. Can we say that? Would you allow me to say that? Okay. So you see, the nasal field of vision of left eye, the temporal field of right eye, okay? So this is the arrangement because of the crossing over of nasal fibers at the optic chiasm. If you look at the fibers now, after decussation, the fibers here are called now the optic tract. This optic tract then goes to the thalamus, lateral geniculate nucleus, synapses there, and then fibers go to the visual cortex to understand or to decipher the vision. Fibers also go to many other places, and I have written that in the notes, you can read that. They go to hypothalamus, the suprachiasmatic nucleus for the day-night cycle. They go to pretectum to control the eye movements, so on and so forth. Okay, so a lot of destinations. But for vision, the fibers will go to the occipital cortex. Okay? Now, got stuck. Okay. If you, for example, this one, the optic pathway, the optic nerve, optic tract, everything is intact. You could see everything, right? Okay, now in this left field of vision, all right, this area is being recorded by which part of retina of the left eye? Nasal retina, right? And this part, temporal retina of the left eye. Remember this, okay? Now, for example, if there is this lesion, the whole optic nerve on the right side is cut. What do you expect the patient to see or not to see? Okay? The whole eye on the right side is gone, right? This is called monocular, one eye, monocular blindness. Monocular blindness. Okay? I told you here you are cutting the whole optic nerve. Okay? The second option, if the optic chiasm is destroyed, so you cut the fibers there. What? Now you have cut the nasal fibers from both sides, so you're going to lose the temporal field of vision on both sides, right? This is called bitemporal hemianopia, also called tunnel vision, because you can't see both sides, but you can see both, in the middle. It's called tunnel vision, okay? If the optic chiasm is destroyed. And this could happen in the cases of pituitary tumors, because pituitary is located just above the optic chiasm. If there is a pituitary tumor which presses on the optic chiasm and damages the fibers there, it would lead to bitemporal hemianopia. Now, if the optic tract is destroyed now on the right side, the optic tract is destroyed now on the right side, what type of visual field defect would you expect? Right? So, nasal field of vision of the left eye, the temporal field of vision of the left eye, nasal field of vision of the right eye is gone. Okay? This is known as homonymous hemianopia. That was bitemporal hemianopia. This is homonymous hemianopia. Okay? Okay, if after the optic tract, once it synapses in the thalamus and then it becomes optic radiation. Now, optic radiation, there are a lot of fibers over a large area. If you have a lesion there, that lesion usually would not be a complete lesion. So it will not be able to destroy all the fibers because they are spread over a large area. You will still have, similar to what you saw in the previous one, homonymous hemianopia, but with one difference. Here all fibers will cut, nothing would pass through. But when the lesion is here, okay, similar defect, but the central part of the vision will be intact. The reason for that is the fibers coming from the macula lutea are very large in number. You need a very big lesion there to completely destroy the central vision. So you will have the same visual field defect, homonymous hemianopia, but with macular sparing of the macula, the fovea centralis of the retina. Okay? If the lesion is at the primary visual cortex on both sides, and as we will see later, this is the area which is concerned with the macular vision, the central vision. If you have lesion there, then you will have what is known as bilateral central scotomas. Okay? And the occipital lobe is at the back of the brain, right? So sometimes the trauma can actually destroy the area which is at the back of the occipital lobe concerned with the macular vision. So you could have bilateral central scotomas. The peripheral vision is okay, but the central vision is gone on both sides. So these are some examples. There are many others, but if you understand these few, I think it should be enough. Okay? All right? Now, visual perception as I told you earlier, the fibers from the optic nerve and optic tract, they go to many different places in the brain. Okay, they go to limbic system, all right, and they play a role in visual reflexes. So I'm not going into details of these. You can study this on your own. So lateral geniculate nuclei, superior colliculus, hypothalamus, the circadian rhythm, pretectum for the visual reflexes, etc., etc. When you look at the visual cortex now, okay, this is the primary area, the one at the back, the primary visual cortex. The macula you see here is right at the back, and a large area represents the macula. Although macula is a very small part of retina, only 0.4 millimeters, I think, very small part of retina. But you see the amount of area which is dedicated for the macular fibers is very large, because detailed vision, cones, right? Each cone synapsing with one ganglion cell, so a lot of fibers are coming from there. Okay? All right, then you have the secondary visual areas which will make sense of what you are seeing. But there is one thing very interesting about how our brain decodes the signals coming from the rods and cones. So it is done actually in layers. There are layers of cells. There are simple cells, then there are complex cells, then there are what we call hyper-complex cells. So the first layer of cells from the same scene that you are seeing, okay, they will only decipher lines. Then the signal will go from these cells to the next level of cells. They will then identify angles and curves. Then this will go to a third level of cells. They will then fill in color, for example. So the image actually is deciphered in layers in these different cells. Because of this, if there is a lesion in the visual cortex or in the optic radiation, you have very peculiar type of presentation that patient will come with. Okay? So, okay, I forgot to mention earlier, there are two types of ganglion cells on the ganglion in the retina. The X ganglion are coming from, if they are bringing accurate vision and color vision, they are synapsing with cones in the retina, right? And the Y ganglions are coming from the rods, because cones are concerned with color vision as well, so they also send signal to what is known as color blob. They are groups of cells which are concerned with filling the color in the image. Okay, so they will, after the image has been drawn, the angles, the basic shapes, then the color will be filled in the image. Okay? So as I told you, simple cells, complex cells, hyper-complex cells, and then the color. So as one goes further into the analytical pathway of the visual cortex, progressively more and more characteristics of each visual scene are deciphered, and then at the end you will see the whole picture. Okay? Association areas, there are certain areas, for example, this area is mainly concerned with the 3D position and the moving objects, and this area is mainly concerned with the visual details and colors. Now, one thing that you should always remember about the neurophysiology, okay, it's very difficult to study neurophysiology because you can't do experiments on humans. And if you do experiments on animals, they're very different from us. So most of the information about these fibers and what is detected in this area and this area comes from patients who have lesions in these areas. So when a patient comes with a lesion in this area, which function is lost? From this we go back, okay, this area was concerned with color vision or moving objects, whatever. So neurophysiology is a field which is not completely understood, but whatever we know, if we know from the patients who present with certain lesions in those areas. Okay? Now some common visual tests, I think you all know. I'll just quickly go through them. This is for myopia, the Snellen's test. You sit at a particular distance, 20 feet from this chart, and you see which lines you can read. All right? This is the normal vision, 20 over 20. All right? If somebody stops here cannot read the lines below, then we say his vision is 20/100, for example. Okay. Hyperopia is you have these, like a newspaper print, different font sizes. So you see where the patient is unable to read, the smaller print. Okay. Then there is field of vision. Okay, there is one test which I think you may learn, called confrontation test. Confrontation test. So the patient sits in front of you. Okay, you ask the patient to keep looking at you, and then you just move your finger. You ask the patient to tell you when he sees the moving finger. You keep moving your finger different areas of the field of vision. Okay, but nowadays there are machines. Your patient sits there, and it's like a dome-shaped structure. The lights will come on different areas. Whenever the patient sees light, he presses the button. So if there's any area where patient could not see, you will know that there is a defect in the field of vision. Okay? The left eye and the right eye, these are the field of vision, and when you look with both eyes, then you have this binocular vision. Fundoscopy is also a very commonly used clinical test where you can see the retina directly. Very important thing about fundoscopy is that retina is the only place where you can see naked blood vessels. Okay? So, for example, in diabetes or in hypertension, if you want to see any problem in the microcirculation in the capillaries, you look at the retina. Okay? For atherosclerosis, for example, the earliest changes you can see in the eye. Alright? So this is the optic disc where all the ganglion cells, axons leave as optic nerve, and the blood vessels come inside to supply the eye. This is the part slightly lateral to the optic tract, which is the fovea centralis, where the vision is the acuity is highest. Okay? Are you clear? Any questions? No questions? Okay? So if you go back to our case study now, particularly at night, what could be the problem? Vitamin A deficiency, good. Night blindness. Okay. And blurred vision in the right and left peripheral field, so there is some visual field defect. Okay. There is myopia and the acuity is 20/100, right? Okay. So basically, vitamin A deficiency, some sort of visual field defect, and there is myopia because his visual acuity is low. Okay. And the visual field defect in this case is double vision. And vision is at optic chiasm. Okay, so this is bitemporal hemianopia, lesion at the optic chiasm. Alright? Okay, so these are some of the references for you to refer to. Okay, and again, there's a Padlet wall. Just put my name, Dr_Akram/vision. Actually, this wall is since last cohort. There are some question answers already there. So you can read them and you can post your own questions if you want. Alright? And now